Good morning, everyone. My name is Dr. Chinmayanand, and today I am here with T&D session related to surgery subject. Those are usually asked in exams. I'll be discussing with you 45 questions. 45 questions. Those are nearly 90 topics. 90 topics. I guess those are the mostly asked topics every year. And when I was preparing for this exam, these topics were on my list for surgery before one day of the examination. Also, I was focusing mainly on surgery because this is the subject where we are expecting every year 35 to 40 questions, 35 to 40 questions every year. And this year also there will be 35 to 40 questions for sure. And from this lecture, whatever the topics we are discussing, whatever the concepts, little bit here and there we are discussing, at least 25 questions will be coming from this. So let's start. First, a patient presented with left lumbar region pain. So left lumbar region pain. After screening, examination, and abdominal radiograph was obtained, and here the image is given. Most likely diagnosis here is. So firstly, we have to do the side determination where whenever we are seeing any X-ray or any radiograph. So in this case, this is left and this is right, and on this image, right is also given. So we have to just choose left stuff. So in this case, which kind of calculus is this? How it is looking? For this, you should know the little bit details regarding to kidney stones. So we have four types of stones mainly. For one, that is calcium, steroid, second and third uric acid, four cystine stones. So in this case, we should know the components or content of the stone. So calcium are generally oxalate and phosphorylated stones. Steroid, these are ammonium, magnesium, phosphate stones. Uric acid, here we have uric acid in this, mostly seen in the gout patients. Cystine, we have cystinuria, that is cystine levels are increased. So precipitation, this is from this question is really asked. In this case, questions can be asked from this as a one-liner. So how many, which are radiopaque or which are radiolucent, and the treatment. For calcium, we use thiazide diuretics or citrate as for like breaking the stones or like making them thin. And then steroid, we have eradicate bacteria. We have to treat the bacterial infection by antibiotics. Then we have uric acid, we have sodium bicarbonate, urine alkalization. This question is related to, I guess, uric acid. It's related to medicine. In this, it's related to here medicine. So one more MCQ extra. Alkalization. These MCQs are related to medicine. So two extra MCQs we have gotten here. Then kidney stones. So radio opaque and radiolucent, what I have said earlier. So there are few stones. There are two stones. These are radio opaque. These are calcium stone and steroid stone. These are radio opaque. You should know the components or the content of these stones and color and shapes. So you can learn from this. These are envelope shape. These are staghorn. These are called as staghorn. So staghorn. And these radiolucent, we have two, that is uric acid stone and cystine stone. These are composed of cystine, yellow or light pink hexagons. These are hexagons. Okay, if possible you can learn this. And rhomboid is for uric acid stones or crystals. So let's come to our question, how it looks like. So probably it looks like a staghorn here. So it's a staghorn calculus. So let's see staghorn. Staghorn, we have steroid calculus. So left renal steroid calculus. This is the answer for this question. This is the explanation you can see. So triple phosphate or calculi it is. Then repeated UTI. So reason, repeated UTI caused by urease producing bacteria like Proteus, Klebsiella, Pseudomonas is a commonly implicated factor. So one question done. Next, coming to the next question. This is, we have a patient present with dysphagia. This abnormality on barium swallow studding filling phase most likely suggests. What does it suggest? So before moving to the esophageal defects, we should know how the stricture and web is, how stricture looks, how web looks, how feline look, and how the diverticulum looks. In case of web, it should look like funnel little bit and it will be coming like this. So it's like a web. Then in stricture, it comes like this, little bit more narrow, and then like this. So stricture will come like this. Then feline, it will be like tiger skin. Alternates will be there, and diverticulum, of course, outpouching. Diverticulum will be outpouching of. So in this case, it's a clear cut. It's a esophageal web, but let's see the explanation. So esophageal web, barium swallow slit-like constriction in the cervical esophagus. esophageal web. Feline esophagus I have already discussed. Hair-like impressions will be there, and narrowing diverticulum will be seen as outpouching. That is, for stricture will show narrowing. This while diverticulum will be seen as outpouching. That's it. We have discussed it. So moving on to the next question. That is the third question. Diagnosis mammography. Diagnosis on mammography. So mammography is in India. It should be performed on a regular basis, like after a few years, after in a particular age group, we should perform this. Especially greater than 30 years, 30-year age group, it should be performed. Especially because it's in India, fibroadenoma is the most common cancer, like most common benign tumor, not cancer, most common tumor we see is fibroadenoma. And where I am working now, that's GMCH Akola. Like in every OT, we will be having at least 2 to 3 cases for fibroadenoma, and it's one of the commonest. So, but in this case, we are seeing this. We are seeing the speculated margins, and it is diffuse one. So it is a cancer most probably. So let's see the explanation. Mammograph shows an irregular apparent mass with speculated margins and adjacent architecture distortion seen on Byrat's 5. So an investigation of choice for carcinoma breast. So mammography is the screening investigation of choice. So 2 more questions we are knowing here. So screening investigation of choice is mammography. So this why I'm writing this, because these are the single liners, or sometime a case will come and at the end they will ask. So this is very important, and here we miss a lot of time. We tend to miss or make a silly mistake, and I have also made some time mistakes. So that's why I'm writing the screening. And then we have investigation of choice, dynamic contrast, enhanced MRI. So dynamic contrast enhanced is an investigation of choice. Overall, it's the overall investigation of choice. So 2 more MCQs we have added on here. Then coming to the next question, that is the 4th one. So till now we did 3 questions, but twice of that is 9 questions we have done, because data is like that, factual data and little bit of concept here and there. So most likely diagnosis on barium enema. Now enema related question is there. So it looks like, what is this? It looks like a sawtooth appearance. So it looks like this sawtooth appearance here we are seeing. So let's see that what is this. So that we should know the sawtooth appearance for this question. So this is the sawtooth appearance related to this. So multiple barium filled outpouchings. We are seeing outpouchings here. In this outpouchings, these are outpouchings we are seeing. So this is a CECT, sawtooth appearance. It is called as sawtooth appearance. Various signs described include bowler head sign. This that we know, no need to that, but arrowhead sign, another name on CECT. So investigation of choice is diverticulosis. Investigation of choice. So what is CECT is the investigation. CECT is the investigation of choice for diverticulitis. So diverticulosis or diverticulitis from colon. So it is a diverticulosis. So next, moving on. So before saying this question, I want to tell this is a JITMER question and images do repeat. So let's discuss this. So CECT again it is. So you must be knowing this question by another. So carcinoma in this case. So this is you must be knowing the basic imaging. So this is sacrum, and probably, of course, in front of sacrum you will be seeing a rectal area. So this is probably a rectum related and carcinoma rectum. So this is answer is carcinoma rectum. So let's move. This is a simple short question, but sometimes we tend to make mistakes, so we should know this. So actual CECT image of pelvis show enhancing intraluminal mass, rectum, yellow arrow, causing luminal narrowing. Apple core sign may be seen on barium enema. So apple core sign on barium enema, when they say, so same we will be seeing in colon. This is apple core sign. This apple core sign is different. One more apple core sign, we have carcinoma esophagus, also apple core sign, but that is in the esophageal area. This is in the colon area. So you have to see the image and carefully mark, because here it's nearby pelvic area. So two and one more, that is one more apple core sign we have seen, that is on barium enema. It's for carcinoma rectum. Then we have this question, diagnosis, simple direct question I am giving, but the reason of giving this is we will be discussing one more question related to it, that is small and large bowel obstruction. So we will be discussing both of them. In this case, what we are seeing is simple, that is valvulae conimentis, or what we whenever we dissect small intestine we see plicae reticularis. During our anatomy years we have seen this, and on radiograph we see like these lines. So this is 100% small bowel obstruction. So coming to the difference between these two, so while seeing this, we are seeing large bowel obstruction and small bowel obstruction. So small, when it's small bowel obstruction, line crosses all way across the bowel. This is plicae circularis. Okay, plicae circularis, and in this case, large intestine, we see its haustras. So haustra, that is line not fully crossing, it will be like this haustra. So haustras. So this is, and in case of large intestine it's a peripheral, and in case of small intestine it is central. So two questions are done, you can read it, and I will be providing this PDF also later, so no need to panic. So next question, moving on to the, so most likely diagnosis is one of the commonest question asked in history of any foreign medical exam or any Indian exam. So this is, of course, it's a diaphragmatic hernia, but we have to see the side again. So this is the left, this is the right, already given. So what should we do in this case? So it is diaphragmatic hernia for sure, but we'll discuss it now in as explanation. How is the explanation? So in explanation, what we'll see, we have two type of hernias, that is Bagdalis and Morgagni congenital hernias. We have diaphragmatic hernia, most common is Bagdalis, and Morgagni is less common. So side. So how to remember the sides? A side is the major thing to remember these hernias. So Bagdalis has LE, and that's why most oftenly LE, that is left, is for Bagdalis. Morgagni has R, so it's a right-sided R. Simple. Morgagni is anterior, and Bagdalis is a posterior. B for Bagdalis, B for posterior or back. So it's learned like this, and mnemonic for this is this. So Bagdalis B, it's big, back and lateral, that is posterior and lateral. Then we have B as bad, that is the prognosis is bad because associated with pulmonary hyperplasia, which is the most common cause of death in neonatal population. Then we have Morgagni hernias, we have discussed. So this is on the left side, so it's left. This must be Bagdalis, and this is the right, probably this must be Morgagni. So let's move on to the next question. Now 35-year-old complaint of fever, severe abdominal pain in epigastrial pain radiating to the back, history of binge drinking, pulse is given 120, BP 90 by 60, CT abdomen was done. Most likely diagnosis is. So before solving this question, why I have taken this question as example, because there was a question in FMGE 2024 where to do plain CT was given, CT scan was given, and normal things were asked. So pancreas they have asked. So what we have to learn is how it looks. So this is the contrast enhanced CT scan of abdomen at level of SMA. So how there is a SMA is a spinal muscular atrophy. So this is, so related to this we should know the structure. So here is the pancreas, here is a duodenum, here is a gallbladder, then comes the liver, then right kidney, inferior vena cava, then left kidney and spleen. So we should know the structures. And now coming to the question, so we should know what's the structure, epigastrium. So they have related to given related to pancreas. Of course, it's pancreas. So now acute or chronic, this comes. So we have to see the complaints for this. We should know it's a sudden onset was there, or they have given history of long thing. In this case, nothing is given. Like back history of binge drinking just given. So back with a history of binge drinking. So how to know it's acute or chronic? So in case of chronic, there will be calcification, and in calcification the picture will look different, and in contrast, and hence probably a calcified mass will be seen as a little bit bright. In acute pancreatitis, it's not that bright, but it's a lobular structure or a little bit puffy or bulky structure is seen. So I will mark it as acute pancreatitis. And now let's see the bulky. So as I have said, bulky pancreas with fuzzy margins and adjacent fat stranding. So sign of acute pancreatitis. So two more question, like one more question we will be adding here. It's CECT is investigation of choice. Acute pancreatitis. So, and Balthazar grading system and CT severity index are used as prognosis. This is also one-liner can be asked, because in FMG, one-liners they ask sometimes they won't. It depends. But let's see. So two more questions we have added. Now coming to this question. So this is in every exam we have 1 to 2 images related to this in radiology or surgery, or sometimes in other different integrated questions. So probability diagnosis based on the finding in CT imaging. So how it looks like a lens. So before discussing this, we should know this different kinds of hematomas. So epidural hematoma. So in epidural hematoma, axial brain showing lens shape. It's a lens shape with skull fracture on the right side here, lens shape. Then in subdural we see moon or crescent. In subarachnoid we see lambdas in between the parenchyma, brain parenchyma. So it is a subarachnoid hemorrhage. And in case of intraparenchymal, intraparenchymal is a hyperdense thing we are seeing. And when this hyperdense becomes little bit dark, it's called as ischemia. It causes ischemia, and the function of a particular side demean or function loses. Okay, so let's come to the question. So what is this? It looks like lens, so it must be epidural, but here in option extradural is given, so it is the most right answer here is extradural hemorrhage. So extradural hemorrhage with a skull fracture, epidural. So let's see the discussion. Most common type of hemorrhage due to trauma, so talk and die syndrome, skull fracture and injury to the middle meningeal artery. So epidural, lucid interval and maxillary artery branch of rupture of middle meningeal artery. Same happens in both, and I guess so extradural or epidural. So moving on to the next question. So mammography is an investigation should be performed in Indian women most oftenly. The reason is we have fibroadenoma cases. Those are most commonly seen in India. In like every 5th or 6th woman comes. For example, where I'm working, that's GMC Akola, we are having like in OT days, we are having at least 2 to 3 cases every day related to fibroadenoma. So let's see what is this. So this is a popcorn calcification. So this must be a fibroadenoma. So let's see the discussion now. So what is this? So how to identify? Of course, it's a macrocalcification. Whenever there is a macrocalcification, it's a fibroadenoma. Microcalcification, that will be related to breast cancer or carcinoma. So popcorn calcification is the keyword here, and your ultrasound will appear as circumcised oval hypoechoic mass, and its length will be more than its width. Typically typically it will be wider than taller. So it's a fibroadenoma. So breast within breast appearance will be the breast within breast. So this is a breast and within breast. That's it. Done. Dusted. Next question is patient represented to the emergency department with severe abdominal pain and erect radiograph. Erect radiograph was done. Based on the finding, the management should be. So this is the recent pattern Jan 2019 or AIMS. Same question was there. So they frequently repeat the questions. So what we are seeing is, so what to do in this case? So air under the diaphragm. Air under the diaphragm. So what is air under the diaphragm? So air under the diaphragm means the intestine must be having a hole, of course, in layman's language. But it, so in this case, what we have to do, we should do a laparotomy. It is the most commonly done. Gastric lavage, making gastric lavage has no sense. ICD is should not be done because chest drainage, it's not related to chest but abdomen. So it's rule out. And USG, how, why not USG? USG, ultrasound only for fluids. So ultrasound is a friend of fluid, so ultrasound is ruled out. So last option is laparotomy. By ruling out, you can solve this question. But let's come to the explanation. That free gas in the diaphragm, perforation, so hole, that is a perforation, hence a laparotomy. Answer is laparotomy. So the best radiograph, whereas CT scan is the most sensitive or best investigation for pneumoperitoneum. So it is pneumoperitoneum case, and the most common and best investigation overall is a CT scan. So one more question added here and done. So extra one more. So let's move on to the next. So 67-year-old hypertensive and diabetic male present with a left-sided hemiplegia. So left-sided hemiplegia is there. Diagnosis based on CT. So first we should determine the side. So always our right side is the left one and our left side is the right one. So in this case, the abnormality is on the right side. So what is this? Previously I have discussed what is hyperdense lesion. Previously we have discussed hyperdense lesion for intraparenchymal hyperintensive hemorrhages. So after some time, these hemorrhages brightness will lose and it will turn into ischemia. So this is a dark thing and it will be an ischemic image. So it is a hemorrhage ischemia. Let's see the explanation. Ischemia and wedge shape. So here, why wedge looks like this? So it looks like it's a wedge shaped lesion or wedge shaped hypodensity in the right hemisphere with loss of gray matter, white matter differentiation is lost, significant mass effect and midline shift. Mass effect and there is a midline shift. Although CT is the first investigation, but DWMRI is the earliest to detect acute infarcts. Whenever there is a wedge shape, mostly is a infarct. So DWMRI, it's a best investigation. It's earliest to detect. So one more question we are added. So next, a patient presented with recurrent abdominal pain. Recurrent abdominal pain is there. So identify the investigation of this image. So what is this? So it is probably a barium related stuff, of course, because all options have barium in it. But what is this exactly? So before you should know the barium stuff. So barium swallow. Is it barium swallow? No, it is not. So we are seeing a small intestine for sure. Small intestine, it's like conimentes, valvulae conimentes. So it must be given from upside. It's like from through mouth it must be given. So it must be a meal. So it's a barium meal. Why not enema? If it was enema, then why it will be coming here? It must be coming nearby the colon region. So barium meal follow through. So let's see the explanation. So it is barium meal follow through as a small bowel is opacified. Look, valvulae conimentes of jejunum in the left upper abdomen. Of course, in the left upper abdomen. Use diagnosis of intestinal tuberculosis, Crohn's disease, Whipple's disease, and nowadays CT or MRI enterolysis is preferred. So this is the one more addition MCQ we are coming. This type of MCQ, like there will be given longer case, and they will be asking the not they will be asking best or nowadays what we are doing. This is CT or MR and enteroclysis. So next question is following image of fast. So this is fast and e-fast, they ask very often. So before moving to this question, you should know what is fast and e-fast. So in case of fast, we have 4. So epigastrium region, so 1, it is the right upper quadrant, then left upper quadrant, then we have suprapubic area, and then we have pericardic area. So along with the pericardic area, we will be adding little 4, I guess we have 4 here and 4. So 4 we will be adding, that is the chest, right upper chest, left upper chest, and then we will be seeing here in lower chest area, and this is lower chest area to see the collection of fluid. So let's see the hypoechoic black dark appearance. So this is the hypoechoic black dark appearance suggests of a fluid collection, probably nearby. Okay, fluid suggests of fluid collection, trauma patient. So it must be a positive e-fast. So let's see the discussion. So you can see here Morrison's pouch, hepatorenal pouch, suggests of free fluid in the abdomen. So this is one more MCQ added. In patient abdominal trauma in whom fast is done, the findings suggest of positive fast implies presence of hemoperitoneum. Patient in hemodynamically stable, CECT abdomen should be done to diagnose solid organ injury. So stable, hemodynamically stable patient, CECT abdomen should be done. Organ injury. If patient is hemodynamically unstable, then exploratory laparotomy need to be done. So one more algorithm. This is the algorithm they do. We have algorithms also to learn this, but I have given this explanation here. So when it is the hemodynamically stable, then we will be doing CECT abdomen. When unstable, then we will be doing exploratory laparotomy. So that's it, e-fast and fast stuff. Now coming to this question. This question is also asked very often. Patient complains of incomplete evacuation of urine and frequent micturition. So what is this? So there is a micturition, a frequent micturition is there, and evacuation of urine is incomplete. So before getting to this question, you should know the normal imaging. So this is the Foley's catheter, fossa navicularis, then penile urethra is there, then bulbar urethra, then membranous urethra, then prostatic urethra, verumentum, and urinary bladder. So what is this? So this is the penile urethra, then again we have bulbar urethra. So and then prostate will come here, and then verumentum, something else. So diagnosis, making diagnosis easy here. Now we know the normal imaging. So this is probably a bulbar urethra. So answer is this. So it's a bulbar urethral stricture. So let's see the, of course it was RGU, retrograde urethrogram. Contrast has been induced into the urethra by cannula passed into the external urethral meatus at the tip of penis. Tight narrowing seen at the lower below consists of urethral stricture. So this is done. Concept is done. Little bit of here and there. Patient present with neck swelling. Next question. Patient present with neck swelling and regurgitation with gurgling sound. Then pressed over the neck. Gurgling sound over the neck. A barium swallow was performed and is revealed here. Most likely diagnosis is. Probably sometime this image will not be given and directly this question will be coming. So direct answer will be Zenker diverticulum. It's a false outpouching. So you are seeing it. So let's see the explanation. Outpouching, posterior outpouching. Keyword neck swelling. Keyword regurgitation such as Zenker diverticulum. Again keyword false diverticulum arising at the Killian's dehiscum above cricopharyngeus. And one more MCQ. Anterolateral diverticulum that arise below the cricopharyngeus muscle, below Killian's Jameson, that arise below. Anterolateral, one more MCQ. So posterolateral is there when it's posterior outpouching. It's Killian's dehiscence when there is anterior Killian-Jameson's diverticulum. So cricopharyngeal muscle is common. So 2 more MCQs are done. So something extra. Then we have this one, that is barium swallow was performed in patient with dysphagia. So what is the most likely diagnosis? So barium swallow again. So why I am discussing this question, these are the most common we'll see findings or most common diseases in the common people we find in India. The reason is spicy food and alcohol, binge drinking, and lot of stuff. So and another related stuff are also there. So you should know the imaging. Two imagings are there. Both are opposite. So when there is a bird beak sign, refer to smooth elongated tapering distal esophagus. It's aclasia cardia. This is aclasia cardia associated with Chagas disease. Rat tail sign is seen in carcinoma esophagus. So this is rat tail sign, and this is carcinoma esophagus. This is not stricture. This is carcinoma esophagus, and you can see this is apple core deformity. Again, you can relate with that. So let's see the barium swallow image. Show an abrupt, irregular, short segment narrowing involving the esophagus, such as rat tail appearance, carcinoma esophagus. Bird beak sign is seen narrowing aclasia cardia. So done. You should know this. So 2 MCQ plus 1 MCQ here also. So 17 multiplied by 2. Again, we have seen a lot of MCQs. So probably this is the last radiological MCQ related to this, because these are most commonly conditions asked every time. So let's do this. Let's read this question. 10-month-old girl, child presented with pain of abdomen, blood in stool, and lump felt over abdomen. So pain in abdomen, blood in stool, lump felt over the abdomen, barium enema was done, and revealed image. What is the diagnosis? So what does it look like? So are you seeing here claw sign or something? I am seeing a little bit probably claw sign and other stuff. So this is a claw. For me, I am seeing a claw. I don't know about you, but it is interoception. Another one you can see, this is here is no intestinal part, or it is, you can't see anything here. So this is probably a interoception. Let's see the. So what we have claw sign. We have present in donut sign. This is a claw sign. We will see this is a coiled string appearance. So what is this? This is the coiled string appearance. This is coiled string appearance, and then this is again keyword sandwich sign, target sign, donut sign, bull's eye sign, and many more. So these are one more question. Investigation. One more question is here, that is in this children ultrasound while in adults in CECT. This can be a one step more question, like sometime in children, adult they may ask separately. In children, ultrasound for sure, and in adults CECT due to radiation issues. Now so radiological part and the radiological part is over. Now coming to the clinical MCQs. So let's start with the clinical MCQ. That is 47-year-old perimenopausal woman present with a 3-week history of green discharge from the right nipple. From the right nipple, that is unilateral. Laterality is shown. On examination, the right nipple is non-tender and has a slit-like appearance and is retracted. The most likely diagnosis. Before solving this question, you should know the discharge type, discharge colors and types. You should know what is slit-like appearance and like what is or where it is seen, and retracted nipple. So you should know this before, that is nipple discharge. So we have 4 types of nipple discharge. First is white, yellow, green, red, or pink. So white or clear, it's seen in physiological condition, breastfeeding, galactorrhea, hypothyroidism, and prolactinoma. And then we have yellow, that is hormonal fluctuation and infection in case. Green, brown, or black, duct ectasia, intraductal papilloma. These 2 conditions. Red, pink, or bloody, intraductal papilloma again, and breast cancer. So depending on the discharge color also we can answer this question. And here we have green discharge. In green discharge, it must be a duct ectasia, that is a mammillary duct ectasia. But this is the wrong way to solve a question. You can't be depending on a discharge color only. You should know one step ahead. And let's see the full scenario or description of this MCQ. So first thing common is you have to decade around the menopause. You should know, you should see the age. So this is around the menopause, 47-year-old. Then dirty or nipple discharge can range from milky brown to dirty green. So I was saying color is not a specific thing to answer this question. So it can be milky or whitish, little bit brown to dirty green. So nipple discharge can be bilateral, and occasionally it associated with cyclical mastalgia and pain. So has the pain given in this? Non-tender is given, but see, question says non-tender, but we can see mastalgia also. So the history of nipple retraction can cause confusion, leading to clinical to suspect breast carcinoma. Retraction is seen in carcinoma, so confusion can be there. However, presence of slit in the nipple coupled with the color of nipple discharge and perimenopausal age of the patient make most likely a duct ectasia. So nipple discharge and perimenopausal age coupled with color makes it color. Color can be a point here, but you can't rely on it only. So galactorrhea is unlikely here as nipple discharge is usually bilateral. So galactorrhea we have to rule out. We'll rule out duct papilloma. Duct usually present with blood. Duct papilloma, nipple discharge, and periductal mastitis does not usually present with nipple discharge and it's common in women in their 30s. So age is also the factor. So that's why I have given this question in question bank, like in this session, because from this we know we can solve more questions. So even if only one answer is there, but we have solved other questions also, like +3. So we have known +3 also. Sometime if they have given another case scenario, you should answer. You will be answering this question this way, or it will be helpful for you guys to solve this question this way. So let's move on to the next question. That is question number 20. That must so multiply to 2 times. That is 40 number question. So 41-year-old woman has noted bilateral, now thin serous discharge from her breast, bilaterality. So we have seen in galactorrhea bilaterality was there. There is no mass associated with what is the appropriate to tell this patient. So first we should know what's this case. So intermittent thin or milky discharge can be physiological. So what they are asking is we should know the true and false statement here. So intermittent thin or milky discharge can be physiologic. Yes, it can be physiological. So true. Express nipple discharge is indication of open biopsy. No, it is not for sure. Absence of mass on mammogram rules out malignancy. Absence of mass on mammogram, no, it's false. Galactorrhea is indicative of an underlying malignancy. No, it's false. Galactorrhea can be physiological. Pathological discharge is usually bilateral. No, not necessary. So let's see the description here. So intermittent thin or milky discharge can be physiologic. Okay, this is a true statement. So nipple discharge from the breast may be classified as pathological, physiological, or galactorrhea. Galactorrhea may be due to hormonal imbalance, that is hyperprolactinemia, hypothyroidism, drugs-related issues, OCPs, phenothiazines, antihypertensive tranquilizers. Then trauma to chest also. Physiologic nipple discharge is intermittent, non-lactational, and due to stimulation of nipple or to drug or estrogen. Both galactorrhea and physiological discharge frequently bilateral and arise from multiple ducts. So pathological nipple discharge can cause benign lesions of the breast, that is duct ectasia, papilloma, fibrocystic disease, or by cancer. This is pathological. It may be bloody, serous, or grey green. In spontaneous or unilateral, can often localize a single nipple duct. Now, straight with mass present, it should be biopsized, and terminal duct excision of the involved duct should be performed. So this is the explanation, and you should know this to solve other MCQs also. So from this you will be getting +2 MCQs related to physiological. That is galactorrhea may be due to what? Maybe hormonal options will be there, hormonal imbalance, phenothiazines or oral contraceptives will be there in option, trauma to chest, and D option will be given, none of the above, or maybe other options or any vague option will be given, and you have to rule out that. So +2 questions and other stuff you will be getting from this question. So +2 more questions you got from this. So now coming to the 21 number question, that is 58-year-old woman, that is menopause of course, menopause-related age, presented to her primary care physician after a scanning of mammogram revealed calcification. So previously we have discussed calcification, macrocalcification, that is seen related to fibroadenoma, benign tumor. Now microcalcification, we are seeing a microcalcifications here and speculated. Yeah, so probably this will be a carcinoma. So physical exam revealed no palpable breast lump or axillary lymphadenopathy. So it must be a breast cancer. So it is breast cancer. So it must be a breast cancer. So I am going with it. It's a breast cancer since microcalcification. So short question. So you can see the description here. That is mammography. So DCS often detected. So pre-malignancy. So most of the time DCIS, that is 50% of invasive ductal carcinoma, if untreated. Calcifications you will be seeing DCIS. Indicate ultrasound is an indication to guide biopsy lesion and findings, that is microlobulated and hypoechoic mass with duct extraction. Post excisional biopsy should be done. Nipple discharge will be there. Overlying this, skin crusting will be there, and typical no palpable mass on examination. This is the perfect case. So it is a 22 number question. So 40-year-old lady was on anti-thyroid medication. This is the first hint. Anti-thyroid medication which she stopped. Sudden stop for 2 weeks. She presented in emergency high-grade fever and hypotension. What is not part of the further management? So firstly, this is a pharmacology related surgery MCQ. So why I am saying this surgery related MCQ? Because they can be asking this one step ahead question. So this is thyroid storm. So in this case you should know the drugs, so which is not a part of. So oxygen, do we give oxygen in thyroid storm cases? Yes, it is possible to, we should give oxygen. Then beta blockers, yes we should, because adrenocorticotropic effect will be downgraded by beta blockers. Then radioactive iodine, I guess no. Lugol's iodine we do give, but radioactive iodine we don't give. So let's see the explanation. What is this? So this is the thyroid storm. Answer is correct, but how it came? So predisposing factor for thyroid storm is cessation of anti-thyroid medication. That was given hint in this question. Infection, thyroid or non-thyroid surgery in untreated thyrotoxicosis. Trauma in patient with untreated thyrotoxicosis. Amiodarone, iodinated contrast agent and radioactive iodine therapy. This causes thyroid storm. And in question, it was given radioactive iodine. So wrong. So we can rule out also. But management, beta blockers to degrade the adrenocorticotropic effect. Then oxygen hemodynamic support. IV Lugol's iodine. Lugol's iodine will, and corticosteroid and PTU will stop the conversion of T4 to T3. So that's why this thyroid storm we use this drug. Lugol's iodine, I guess, bind to excess thyroid hormone and decreases the thyrotoxicosis. So let's move on to the next question. So not next question, but this concept is important here. So you should know the Graves versus Hashimoto thyroiditis findings. The reason for this is because this time, like last Jan exam also, they have asked related to Graves and Hashimoto's. Same questions were there, like same related questions were there, and a little bit confusing. So you should know the basics. So what happens in Graves disease? Graves disease, antibodies result in stimulation. Graves antibodies are that result in stimulation of thyroid cells, and that related to the goiter. In Hashimoto thyroiditis, antibodies result in destruction of thyroid cells. So in Hashimoto, first there will be destruction, and that will lead to the thyrotoxicosis. Later it will normalize. Later it will come to normal, and later it will come like more hypothyroidism. Since cells get disturbed, so it will be like this. So it will normal range, and then it will come as a hypothyroidism. So Hashimoto has like this curve. In Graves has a single stage, that is hyperthyroidism. Graves has like this, Hashimoto. So one more thing you should know about the symptoms, that is bulging eyes. Exophthalmos will be in Graves disease, and Hashimoto thyroid does not cause protrusion of eyes, no exophthalmos. Then pathological findings, hyperplasia will be seen in Graves. Hashimoto will show follicular atrophy. Then another name of Graves we have termed as diffuse toxic goiter. So you can see on radio iodine uptake, that is, this is Graves. Sometimes they will be giving scans, that is RAIU, that is radioactive iodine uptake scans will be given, and they will be asking, it will be like this, and they will be asking what is this. So it will be diffuse toxic goiter or just Graves disease. In toxic and in Hashimoto thyroid is also known as lymphocytic thyroiditis. Lymphocytic, that will be related to pathology. In pathology there will be images, slides will be there, so you can relate with that. So this is toxic multinodular, multiple nodules are there. This is toxic adenoma, and this is normal. And hyperfunctioning or hot nodule hyperfunctioning or hot nodule look like this, and it's 10% malignance, isofunction, warm, and cold nodule is uptake is less than surrounding thyroid. So but it is malignant. Malignant is a cold one, and this is warm one, and this is a hot one. So this you should know this, basics you should know before going to the exam, because basic questions are asked, and in Jan exam also questions related to this were asked. So let's move on to these are the basic symptoms: hypo and hyperthyroidism. Everyone must be knowing it. Cold intolerance, hypo; decreased sweating, weight gain, constipation, depression, and irritability, irregular and heavy periods, slow heart rate, brittle nails, muscular or joint pain, and puffy face, hypothyroidism. Because since the metabolism is decreased, that's why hyperthyroidism metabolism spikes up, and so weight loss or weight gain will be there. Sometimes weight gain also, but weight loss is the most prominent. Short and light period, increased sweating, puffy or bulging eyes. Then heat intolerance, that is heat intolerance, nail thickening and flaking, nervous and anxiety, muscle weakness, racing heart, and diarrhea. So this you should know the basic steps. So now coming to the question number 23. So 48-year female with family history of pheochromocytoma is undergoing laparoscopic nephrectomy for newly diagnosed renal cell carcinoma. The surgeon note an adrenal mass not previously seen on imaging. Manipulation of kidney causes severe hypertension. 225/135. The case is aborted, with the patient transferred to the intensive ICU for blood pressure management. In this scenario, which of the following biochemical testing most recommended? So we in pheochromocytoma we do plasma that is 24-hour urine catecholamines, 24-hour urine catecholamines, 24-hour urine so in pheochromocytoma we do 24-hour urine test, that is, but is it catecholamine or is it fractionated metanephrine? It's a big confusion, and in this case the BP, that's blood pressure, is 225/135. So you should know the concept before. So what is pheochromocytoma? Pheochromocytoma is adrenal cortex, is a tumor of adrenal gland, and it looks like this. In this case, right? So clinical presentation. So spontaneous severe anxiety, signs of increased heart rate and blood pressure. So what we are seeing here, so it's a spontaneous. Dopamine will be increasing. Dopamine agitation and psychosis will be there. Non-efficient fight or flight response will be there. Blood and urine labs, catecholamines and metanephrines will be increased. So we have confusion here now: catecholamines or metanephrines. So let's see. So catecholamine metabolism, dopamine increases and homovalenic acid increases, and in norepinephrine and epinephrine, then vanillyl mandelic acid increases. So metanephrine, and so according to this algorithm, what we have, we should test it like this. So complete. So what they are saying, 24-hour urine collection are preferred, of course, but fractionated metanephrines, 24-hour fractionated metanephrines, most specific assay, and plasma-free metanephrine are most sensitive. So plasma-free fractionated metanephrines or 24-hour urinary fractionated metanephrines, this should be among these two must be the answer. So in this question, what we have is 24-hour catecholamines and 24-hour fractionated metanephrines. So I will go with 24-hour urine fractionated metanephrines, urine fractionated, because it's the most specific, may be used as a first test for low suspicion cases and also as a confirmatory study in patients with a less than two-fold elevation in plasma-free metanephrines, the highly desirable population. So I will be going with this. So this is the answer for sure. Okay, so let's move on to the next question. So in this question, if you find I am marking it as wrong, but there will be different opinions, but according to my research, it should be 24-hour urine fractionated metanephrines. So you can comment in the comment section. You can comment down in comment section regarding this answer, but according to the research and previous year questions also, this answer is this. So let's move on to the next question, that is number 24. So let's come to the next question, that is 24 number question, that is 38-year-old woman present to the emergency department with a one-day severe flank pain. Also notes that she had intermittent watery diarrhea for past few weeks. On physical exam, mild abdominal tenderness to palpation, particularly in epigastric region related to pancreas. It means an upper left quadrant as well as costovertebral angle tenderness. Lab shows hypercalcemia and ultrasound shows the presence of kidney stone. So this must be, there is a confusion here, so confusion created. So kidney or pancreas. So according to this, we should be answering. So severe flank pain, epigastrial region and upper left quadrant, it must be pancreas. So let's move on. So let's see how to solve this question. So for this question, we should know this three types, that is men 1, men 2A and 2B. So 3 P's in men 1A, pituitary, parathyroid and pancreatic. So for now, my answer should be men type 1. 2A, 2 P's, that is pheochromocytoma, parathyroid and medullary thyroid cancer. So in this R question, there is no medullary thyroid cancer related, so 2A probability gone less. Parathyroid related not given, so parathyroid related stuff not given. Then pheochromocytoma not given, so this is ruled out. Men type 2B, 1P, the pheochromocytoma, medullary thyroid no related. So answer is this. So I will go with this, multiple endocrine neoplasia type 1. And one more thing I want to add is we got 2 more MCQs, that is pheochromocytoma is seen in 2A as well as 2B, medullary thyroid cancer is seen in 2A and 2B. So 2 MCQs we have got. Marfanoid habitus 1+1 and medullary thyroid cancer 2A +1. So we have got 5 MCQs here. So with this, so let's see the explanation. So answer is men 1A, that is also called as Wermer syndrome. And previous called as carcinoid tumor, rare pheochromocyte as well as tumor, other parts of digestive tract, non-endocrine, also seen in men 1. These tumor can include these much. Okay, so you have to learn this, but to solve this question, this much thing is enough. If you know this, this is done. So let's move on to the next question. that is 25 number question. So 46-year-old, right? 25. So let's move on to the 25th question. That is 46-year-old man is evaluated for abdominal pain in the right upper quadrant and fever of 1 month duration. He recently emigrated to Mexico. His medical history is unremarkable and he takes no medication. On physical examination, temperature is 37.7, that is 99.9 degree Fahrenheit. Vital signs are normal. Abdominal examination shows tenderness to the palpation of right upper quadrant. Right upper quadrant related to liver then. So let's move. No skilled icterus noted, no jaundice. The remainder of examination is normal. Ultrasound of liver shows a fluid containing structure and complex wall consisting hepatic abscess. They have given completely it's an abscess case, hepatic abscess or liver abscess. So laboratory study shows leukocyte count of 10,600 per microliter. Testing of for enta-amoeba histolytica Ig positive. So what is this case? So before knowing this, there are two more differentials with this. So you should know this table. So this table. So comparison for this, you should know this table. So pyogenic abscess, amoebic abscess, and hydrated cyst. So pyogenic, often multiple etiology will be there. Amoebic is usual single, and hydrated cystic and septation and eggshell calcification will be seen. So in our question, what is given? Fluid containing structure, complex wall consistent with hepatic abscess. So in our question, hepatic abscess or cyst is completely given, and enta-amoeba abscess is given usually single. It's a complete one thing is given. So there was given fluid containing structure, complex wall consistent with hepatic abscess. Clearly they have made complex one, so probably it is single stuff. So let's see. So it's a single stuff, and enta-amoeba histolytica was again it was a history clincher, or it was a hint for us. So diagnosis for this ultrasound and CT. So we are seeing it's amoebic cyst. This is anchovy sauce or anchovy paste or chocolate sauce is there. So treatment for this you should know: metronidazole 750 mg TID 7 to 10 days, or tinidazole followed by paramomycin, another therapy to eliminate intraluminal cyst. So this should be, they have asked this answer. So we have got on. So they have asked this question. So this is our answer. But before moving to that, you should know other two conditions also. So either location, if it's either lobe of liver, presentation is subacute, and there is a left shift present, that is leukocytosis or left shift is present. So polymicrobial or Staph aureus, Staph pyogen, E. coli, and Pseudomonas and pneumonia is given. And like this imaging is given, then it's needle aspiration is needed, catheter drainage or IV antibiotics are needed. Then this pyogenic. So multiple pyogenic abscesses or hepatic abscesses in multiple word is given. If it's multiple, so if multiple word is given, then it's a pyogenic abscess. Now in case of cystic, there hydrated cyst, there will be septation and eggshell calcification. There are septations and eggshell calcification is there. So it's clear cut. So you have to do surgery in this case, percutaneous management, drug therapy, observation, and see next WHO stages. So percutaneous management is there. So in this case, it's a chronic. Usually right hepatic lobe is affected in this case. In this pyogenic, both, like either lobe, maybe right or left. And one more, that is leukopenia is there, and mild eosinophilia predominance. It's with hydrated cyst. So and echinococcus is the etiology. So CT or ultrasound is the diagnosis of choice here. To diagnose, we should do CT or ultrasound and serology. So echinococcus is a clincher here. A right side is a clincher. Cystic is a clincher. In pyogenic, multiple, either lobe, left shift present is one more. and these etiologies or culprit pathogen, and this is the same, and here culprit pathogen. So easiest. And this question, so one question, one question, two question, third question, one first question, so we got one question, so we got more questions, that is first, second, third, fourth, fifth, sixth on imaging basis, then pathogen basis, one more. So from this table at least 10 MCQs can be made. So this table is very high yield, and this question, that's why, that was the reason of asking this question here. So answer must be metronidazole and paramomycin. So done with this question, 25th number question. So see how many questions, nearly 60 questions we have done till now. So, or 60 topics we have done till now. So now next question, that is 26 number question. So 68-year-old man undergoes surgery for aortic aneurysm. 20 days later he brought back to the hospital with upper GI bleed. What is the probable cause of this bleed? So this is one-liner. This was a one-liner asked many years ago. As per my research from Mayo Clinic, I have taken this question, and the reason of taking this question is to discuss the upper GI bleed and lower GI bleed. So before that, you should know what is the upper GI bleed, and before this, you should know what kind of bleeds we have. So this is a direct question. Now the answer is aortoenteric fistula. So here the answer is aortoenteric fistula. So this question has been taken from Mayo Clinic website, and reason of taking this question is to discuss GI bleeds, upper GI bleed and lower GI bleed. Further I will be discussing, but here it's related to esophageal varices and aortoenteric fistula, and aortoenteric fistula is the answer. So let's see the discussion. Why GI bleed after surgery of aortic aneurysm can be fatal, and the first possibility is aortoenteric fistula. So background of GI bleed, what we have: dilated vein that develop within the lining of lower esophagus that results in this. Varicose bleeding is the most common complication. 25 to 40% individuals are with varices here. So this burst, and this will result in the upper GI bleed. What we see here, GI bleed for now. So for diagnosis we do upper endoscopy graded based on size of risk and bleeding causes. Direct portal hypertension. Portal hypertension is the most common cause, and usually cirrhosis, portal vein thrombosis, right-sided heart failure, and cystosomiasis. So from this you can expect like 3 questions, 3 MCQs can be made from this parent MCQ. I will say parent MCQ, 3 more MCQs, so 4 MCQs. So we will discuss is upper GI bleed, and when I will discuss upper GI bleed and lower GI bleed, you will get more clarity on this. So let's move on. So how the esophageal varices are treated. So propranolol and nadolol, these are the non-selective beta blockers, can be used, administered in individual order to portal blood flow, individual to decrease the. So these are administered to decrease the portal blood flow, and then we can do blood transfusion also of octreotide, somatostatin, vasopressin. These are vasoactive agent can be used, and definitive treatment for portal hypertension we can use TIPS, that is a transjugular intrahepatic portosystemic shunt can be used. Can esophageal varices cured? May vary, size different, evolution, but nowadays in all cases, though, treatment is centered on preventing and reducing the risk of complication, but cure, not sure. So let's move on to the next question now. A 27th question. 45-year-old lady present to the hepatobiliary clinic with a large 3 cm stone in the neck of gallbladder eroding into the common bile duct. So it's related to gallstone, and it's eroding the common bile duct. This is a one step or the 2-step question, that is a 1 step ahead question. This effacing 50% of its diameter. Patient has been counseled about surgery and willing for same. What would be the most appropriate surgery? This is uh, question related to Mirizi syndrome. So you should know the grading before solving this question. That is a sense classification of Mirizi syndrome: type 1, type 2, type 3, and type 4. Type 1 is the only classification where external compression of the common bile duct happens, and remaining they will be involving less than 1/3 of the circumference, then 2/3, and destruction of the wall. So they will be destructing the wall. So Mirizi type 1. So before knowing this, so how it happens. So this is the in the neck cystic duct here in common bile duct. This is a common bile duct, cystic duct. If the stone gets incorporated or stone gets stuck here, it can get stick to this and can form fistula with this, and that will lead to Mirizi syndrome. And that's the reason. So the stone compresses the common bile duct. So the stone compresses the common bile externally and can lead to fistula formation of CBD. Patient will present with pain in abdomen, jaundice, and fever. So in this case, what should be the treatment? So treatment is, if it's type 1 Mirizi syndrome, treatment is fundus first cholecystectomy or partial cholecystectomy. For type 2 to type 4, in this case, patient has been counseled, and in this case, common bile duct. In this case, 50% of its. In this case, larger than 3 centimeter stone is in the neck of gallbladder, eroding the common bile. Eroding, the word is used. So since the eroding word is used, it must be among the type 2 to type 3 or type 2 to type 4 category. So we should be doing cholecystectomy and Roux-en-Y hepaticojejunostomy. So what we will be doing, so we will be cutting here, and here we will be directly make connection between hepatic duct and the jejunum. So this is the surgery, Roux-en-Y. So that is hepaticojejunostomy, direct we will be doing. So that's the answer for this question. This is the one step ahead question. So, and you can mark it as star, because sometimes the difficult question they ask and they will be asking, so vague questions can be asked, and this is asked in JITMER and AIMS questionnaire, so that's why I have taken it. So questions do repeat. Then we have 28th question. So 45-year-old Asian lady is a hint, emergency department of intermittent epigastric pain. Pain is intermittent. Pain is severe, lasts for 3 to 4 hours, and is often associated with vomiting. Her bowel movements are normal. She is febrile. Heart rate is 110. She has a mild icterus and bowel sounds are normal. She has an inspiratory catch of breath on deep palpation. The TLC is 13,000 and bilirubin is 3.3. Direct fraction of 2.7. Liver enzymes and alkaline phosphate are normal. What would be the next investigation? So next investigation. So what is this? Intermittent epigastric pain. So I am Asian, intermittent epigastric pain. It must be intermittent epigastric pain, cholecystitis. So first you should diagnose this case, and now this is the one step ahead question again. So what would be the next investigation? In this case, next they are asking next investigation. So it should be ultrasound, USG, but if they ask the investigation of choice, then ERCP. So 2 questions are done and dusted from this. So let's see the explanation. So lady present with typical feature of acute cholecystitis, female 40s, right upper quadrant pain, more often than not has gallstone. Ultrasound is the first diagnostic modality for detection of acute cholecystitis. Its wall thickness more than 4 mm, pericholecystic fluid X-rays and CTs are not much sensitive in detecting gallstones. So this is the thing. So now this table is very important because this time also in Jan they have asked questions related to this. So acute pancreatitis, you should be doing CT scan, all space accumulation, MRI brain, calculus cholecystitis, HIDA scan. Then we have anal fissures, its local examination under local anesthesia, aneurysm angiography, FES. Any paranasal sinus, we do FES. Then we have amyloidosis. Then any other condition here is not okay. Aortic dissection, we have patient stable, then MRI, patient unstable, then transvaginal endoscopy. Any metastasis or muscle soft tissues, MRI, calculus cholecystitis, ultrasound, cardiotoxicity, you should learn this, FLAIR MI and FLAIR MI for chronic subarachnoid hemorrhage, chronic, FLAIR MI, MRI. Then another important stuff, we have diverticulosis enema, we have done in questions, so same questions were taken, CT scan, diverticulitis, CT scan, and ankylosis difference, manometry, diffuse esophageal spasm, DES, we do manometry, aclasia manometry, motility disorders. So this is another one more question they ask every time. Manometry is done in diffuse esophageal spasm, aclasia, and motility disorders. Motility related disorder, Down syndrome echo for sure, DCIS mammography, as we have learned earlier, emergency cases, stable patient, fast, esophageal perforation, flexible endoscopy, gastric bleed, we do RBC scan, and many more. So this chart is very important. You will be getting at least 7 MCQs from this, and previously we have discussed more also. So moving on to the next question. So moving on to the next, first let's discuss this concept. So this is related to gallstones and gallstones stuck in the common bile duct. So causes, chemical imbalance, gallstones, most common cause chemical imbalance within the gallstones, gallbladder. So let's discuss about gallstones a little bit. Chemical imbalance causes gallstone, cholesterol, gallstones are excess cholesterol, pigmented gallstone, excess bilirubin. Then background, hardened deposit of bile that form hardened deposits of bile that form in gallbladder, aka gallstones, can range in size. Now signs and symptoms, usually asymptomatic biliary colic and severe rapidly intensifying abdominal pain localized to upper right quadrant or central abdomen, triggered at night after fatty meal. Fatty meal is a clincher or a hint giving, or keyword is a fatty meal. Diagnosis, abdominal ultrasound, endoscopic ultrasound, ERCP, as I have said earlier. So for diagnosis, this is very important from this two questions. ERCP is a diagnosis we can do. Endoscopic ultrasound is the first investigation, then as a treatment ERCP can be used as a treatment too. So let's move on to the next question now. So these are the cholesterol stones and pigment stones. Looks like 10 to 20% are radiolucent, and radiopaque are pigmented stone, hemolysis or radiolucent infection, and this is Crohn's and several conditions we can see the stones. So you should learn this by heart. I will share the PDF later. Now this is Whipple's procedure. On this questions will be asked. So this is the topic. I will not be making any question on this, but I will be asking a question. So what are the components of Whipple procedure? That can be questioned. So one, it will be choledochojejunostomy, that is the bile flow from liver is re-established. that is bile hepatic duct is attached to the jejunum directly. This is the first. Then we have gastrojejunostomy for passage of stool, that is stomach and jejunum is attached. And then we have pancreaticojejunostomy, that is pancreatic secretion should be released in the jejunum. That's why flow of pancreatic juice is re-established after. So this is the before and this is after. This is done in pancreatic cancers. And it can be asked, and it's asked many times in FMGE. So this is done in pancreatic cancers. Then coming to the next question, that is 29th number question, I guess. Okay, let me see. Yes, 29th question. Whipple stride. Now Whipple stride. Before solving this question, Whipple stride pathological condition, you should know all this condition plus one more condition, that is gastrinoma. So let's discuss these conditions first. So what are these conditions? Insulinoma, gastrinoma. So these are, first let's discuss insulinoma. It arises from the beta cells of pancreas. It's in tumor. And gastrinoma arises from G cells, G for gastrinoma and G for G cells of pyloric antrum, pancreas and duodenum. So 90% are benign. 90% of insulinomas are benign, and 90% of insulinomas are benign, and 80% of gastrinomas are malignant. Whipple stride comes under insulinoma. So Whipple stride contains symptoms of hypoglycemia, low blood sugar less than 40 mg/% and it relieves with glucose. So this is the Whipple stride. We have got our answer. So still we will discuss further. Severe peptic ulceration at atypical site, hypergastrinoma will be there. Then site, equally distributed throughout pancreas. Gastrinoma, it's distributed in the Pazzaro's triangle, Pazzaro's triangle, an imaginary space marked by cystic duct, duodenum, and the junction of neck and the body of pancreas. You should know these three boundaries. It can be asked as a separate question. So +1. Then we have investigation for insulinomas is 72 hours fasting test. Insulin is to glucose ratio should be greater than 0.3. Increase C-peptide and intraoperative USG, it's needed. So this can be asked as a single liner sometime. So +1. Serum gastrin level greater than 1000. Basic acid output greater than 151. Endoscopic ultrasound investigation. This is for gastrinoma, +1. Then management, insulinoma, head of the pancreas if it's involved, then enucleation, body or tail or close to duct, then distal pancreatomy. So this is +2, two more questions. This can be asked in the form of single liners, or it can be asked in the form of clinical case. So then we have in gastrinoma, pancreatic gastrinoma is the enucleation plus peripancreatic lymph node dissection, +1 question. Duodenal gastrinoma less than 5 mm is the enucleation. One more question. Duodenal gastrinoma greater than 5 mm excise with full thickness excision duodenal wall. One more question. So 6 to 7 questions here again. See, from 2 topics. So anything can be asked, like they can make it round and round. Okay, so next is glucagonoma. Glucagonoma is a tumor of pancreatic islets that leads to elevated level of glucagon. Glucagon is increased and gluconeogenesis is increased and amino acid oxidation is increased. So there are 5 Ds related to glucagonoma. 5 Ds. So in this 5 Ds, so D is dermatitis. Then we have diarrhea, then we have deep vein thrombosis, then we have diabetes and depression. These 5 Ds. So there was a question related to glucagonoma, 5 Ds. They were given 5 Ds, among different Ds were given, and one of the options were interchanged, and they were asking which one of this is not part of glucagonoma syndrome. Then it was this. So it will necrolytic migratory erythema also seen in this glucagonoma syndrome. So got one more question. So +1. So Many questions. Still we are just on 29th number of question. Whipple stride. So now Whipple stride is seen which insulinoma. What are the components of Whipple stride? Components of this hypoglycemia, blood sugar, like hypoglycemia, low sugar levels, and relief with glucose. So these were the components. So and last I want to discuss VIPoma also. VIPoma. So first we should know what is VIP. That is vasoactive intestinal peptide, also known as peptide hormone that vasoactive intestine. Uh, result in secretion. So it it keeps a check on secretion, body secretion. So when there is a tumor of this, it will result in watery diarrhea, achlorohydria, and hypokalemia, and it will result in hypokalemia too. So what we do, investigation CBC, and hyperglycemia will be seen, AKI, hypokalemia will be seen. This is the main stuff. Then CT, MRI, abdomen imaging, endoscopic ultrasound can be done. So CT, MRI is the main. VIP concentration greater than 76 picogram per ml. Symptoms triad, that is the most important. VIPoma, this can be asked as a question, +1. That is watery diarrhea, hypokalemia, and achlorohydria. So this is the question. Then management, initial management, volume resuscitation, and correlation of electrolyte abnormalities. Because a lot of water is lost and electrolytes are lost, we have to increase the fluid levels of patient. So in this case, resuscitation and correction of electrolyte abnormality should be done. Mainstay of treatment is surgical, and other treatment and conservative management is here. So you should know this. Now, function of VIP, as I have discussed, stimulate secretion of water into the pancreas, reducing bile, common inhibition of gastric acid. So it keeps a check on secretory action of intestine as well as stomach. So greatly stimulates secretion of water and electrolytes. So that's why you should know these tumors. Then number 30. So not component of macular triad, Mackler's triad. This is an important question again. So before knowing the before knowing this triad, that is Mackler's triad, you should know these two conditions, that is Mallory-Weiss and Bohr-Haave syndrome. Mallory-Weiss, before solving this question, Mackler's triad, you should know these conditions, that is Mallory-Weiss and Bohr-Haave syndrome. So tear in Mallory-Weiss, what happens? Tear on the gastric side of the gastroesophageal junction, which may extend to distal esophagus. It's just a mere tear. But in case of Bohr-Haave, it is a complete tear or complete rupture of lower thoracic esophagus, and it's mainly seen in and Bohr-Haave syndrome has a Mackler's triad, which include chest pain and shock, subcutaneous emphysema, Hammond's sign, subcutaneous emphysema, complete rupture. So Mackler's triad include, before knowing the Mackler's triad, you should know these two conditions, Mallory-Weiss syndrome and Bohr-Haave syndrome. Mallory-Weiss syndrome is due to tear on the gastric side of the gastroesophageal junction, which may extend to the distal esophagus, which may extend to distal esophagus, and it's just a mere incomplete tear, only affects mucosa and submucosa. But in case of Bohr-Haave, it's a complete rupture at the lower end of thoracic esophagus. So before knowing this Mackler's triad, you should know these two conditions, that is Mallory-Weiss and Bohr-Haave syndrome. Mallory-Weiss is just an incomplete tear, only affects mucosa and submucosa, and specifically at the gastroesophageal junction extends to distal esophagus. In case of Bohr-Haave, there is a complete rupture at the lower thoracoesophagus. And in case of Bohr-Haave, there is a complete rupture at the lower thoracic esophagus. So what we will see in Bohr-Haave syndrome, there will be Hammond's sign, that is crunch sound upon auscultation of the heart due to pneumomediastinum, and there will be a sign like this. So since there is a rupture, there will be content in the chest area, that will looks like this. In case of malarides, you will see this, but it will not be prominent like this. Okay, so let's come to the macular triad. Macular triad includes repeated vomiting, yes. Belching, no. Subcutaneous emphysema, yes. Sudden onset chest pain, yes. So this is the answer. So now coming to the 31 number question. 73-year-old man present with several episodes of hematemesis. Examination shows sign of orthostatic hypotension and melena. Whenever there is a melena, you should tend to answer it's upper GI bleed. It's what is the first priority in caring of this patient? What is the first priority in caring for this patient? So what should be the first priority? Before moving on to this question, you should know the basics for this question. That is the gastrointestinal bleeding. So upper GI bleed and lower GI bleed. So we have this line. There is a ligament of Treast. There is a ligament of Treats, or there is a ligament called as ligament of Treves, ligament of Treads, ligament of Reeds, there is a ligament of Treads, suspensory ligament of duodenum. So above this ligament and below this ligament. So above this ligament, everything what we have, that is esophageal varices, esophageal perforation, Boer-Haave syndrome, Malarides syndrome, and Diploid's lesion. This come under the upper GI bleed. And lower GI bleed, we have intestinal angiodysplasia, intestinal ischemia, hemorrhoids. This comes under the lower GI bleed. Presentation: hematemesis, coffee ground vomitus, this and melena. This comes under the upper GI bleed. So upper GI bleed, what we see as peptic ulcer, upper GI bleed as a peptic ulcer, variceal bleeding, malignancy. Lower GI bleed, diverticulosis, angiodysplasia, colorectal carcinoma, ischemic colitis, hemorrhoids, and many more. So one more thing I want to add here is this: hematemesis, whenever they say it's a upper GI bleed, 2 occult blood positive brown stool, that is the coffee ground, 3 coffee ground emesis, 4 melena, and hematochezia, occult blood in stool, that is a fresh blood, that will be a lower GI bleed. So hematemesis, you should learn this, it's easy. And then we have background. There will be back tar like sticky stool with strong foul odor, that is melena. From upper GI, bleeding will be there, not to be confused with the hematochezia. As I have discussed, fresh blood will be there, a red colored stool, blood originated from the lower GI. Symptoms: mild blood loss dependent on source of bleeding, abdominal pain, painful swallowing, indigestion, vomiting, and everything like this. Treatment: proton pump inhibitors to decrease the acid to treat the peptic ulcer. So symptomatic treatment for every condition. What we can do: endoscopic therapies can be done, then angiographic embolization, surgical therapy, blood transfusion. And this is the causes of upper GI tract bleeding, as I have discussed earlier. So coming to next question, that is question number 32. Question number 32, that is coffee bean sign seen in. So this question can be asked again. So it's sigmoid volvulus. So you should know the difference between two conditions. That is, this is a coffee bean sign seen. The sigmoid volvulus. Appearance of the folded over distended sigmoid colon on plain radiograph of abdomen seen in sigmoid volvulus. Other signs are bent inner tube sign, omega sign, liver overlap, etc., etc. So these two things can be seen. So how to differentiate cecal and sigmoid volvulus? More common in older patient, that is sigmoid volvulus, Parkinson's disease related, multiple sclerosis, chronic schizophrenia, coffee bean sign. So you can see this, and large intestine will be involved. So sigmoid volvulus. In case of this, in case of cecal volvulus, younger patient, distal colon usually empty, small bowel frequently distended. So small bowel frequently distended. In this, large bowel. So stack of coin appearance will be seen in cecum. That is cecal volvulus, stack of coin appearance, a small bowel dilation. That is done. So these are few differentiating points. Torsion in the sigmoid will present large intestine, sigmoid, cecal torsion in the cecum, large intestine. Arise in the left lower portion of the intestine, of course, right lower portion, large bowel dilation, small bowel dilation, mostly affect older, younger adults. younger patient, adults. Second most common volvulus initial examination and treatment includes sigmoidoscopy. Yeah, here cecopexy. Now, coming to the next question, that is 33 question. This is an important question. Again, it was asked in AIMS previous year. It's among the AIMS previous year MCQ. So, 3-year-old male child present with history of constipation, abdominal distension for last 2 years, plain radiograph abdomen reveals fecal matter containing distended bowel loops, barium enema, subsequently shows a transition zone at a rectosigmoidal junction with a reversal of rectosigmoidal ratio, probable diagnosis. So, meconium is not passed, I guess, so it must be a Hirschsprung disease. So let's see how to diagnose it. So what, why, and how. So what? Hirschsprung disease is a congenital condition. Then extreme cases can lead to intestinal obstruction. Why? Why it happens is aganglionosis. So why it happens is due to aganglionosis, and symptoms include constipation, what we have seen in this question, abdominal distension is there, bilious vomiting is not given but it is there, not passing meconium in day 1 of the life. So constipation and abdominal distension was the sign given mainly. So that's why I have marked this question as constipation, abdominal distension, last 2 years. So Hirschsprung disease. So, and now how? Diagnosis is made through a combination through voiding history and biopsy to confirm aganglionosis. Consult with surgeon, abdominal x-ray can be done, and symptomatic relief can be given via bowel wash. Surgical correlation is the ultimate treatment. So that's the question done. So how in this also there will be aganglionosis 1 question, aganglionosis 1 question. Symptoms can be asked sometimes, and I guess that's a diagnosis. Now 34th question. A 20-year-old woman present with fatigue and pallor. On routine blood test, she is found to have iron deficiency anemia. On physical, she has multiple freckles around her lips and some inside her mucosa. Her primary care physician is concerned with the freckles and may not be actually freckle but lesion something. Doctor who schedules for endoscopy, what is the diagnosis? So in this case, before going to this question, you should know what is this. So first showing anemia, then freckles around the lip. So freckles, it's a Peutz-Jeghers syndrome or Peutz-Jeghers syndrome. It's a Peutz-Jeghers syndrome. So how to diagnose it? So it is firstly, several MCQs can be asked. It's an autosomal dominant condition. Firstly, so question number 1. Then it can be a mutation STK. It can be the hint. Then benign hamartomatous polyp in the gastrointestinal tract and hyperpigmented macules on lip and oral mucosa. Melanosis. So melanosis sign are there. So tan dark clinical features can be seen on mouth, eyes, hands, feet, anus, genitals. Appears before 5 and fade after puberty. Dark brown, bluish black patches. So this is the GID polyp occur late, and small intestine intussusception, pain in the Bailey area, cramping pain in the Bailey area. So and malignancies can be associated with it. So this is the question, and many questions can be made. This time in exam in Jan there was a straightforward question. Neurofibromatosis 1, which kind of inheritance? So they can ask this time maybe Peutz-Jeghers syndrome, which kind of inheritance? So that's why this is the main question for you, for us probably, not us but for you. Okay, so this is the presentation I have discussed. Now 38, I guess, 38 number question. So let's move on to the 35th question. 35th question. 57-year-old male come to a surgery clinic with bleeding per rectum. He diagnosed with hemorrhoids. Is diagnosed. What is not indication of hemorrhoidotomy? It's a not indication. So we have to not indication we have to find. So before this, to solve this question, you should know the grade of hemorrhoid. So there are four degrees of hemorrhoid or grades. First degree, bleed only and no prolapse. So when there is a prolapse, it becomes a second degree. When there is a prolapse plus have manual, it reduces manually and not spontaneously, then it's a third degree. Prolapse with spontaneous reduce is a second degree, and fourth degree permanently prolapsed. So in this case, what so surgery for bleeding diagnosis of hemorrhoids, what not indication hemorrhoid, persistent second degree hemorrhoid 5 days after sclerotherapy. Third degree hemorrhoid, of course, hemorrhoidectomy you have to do. Fibros we can do. Internal external hemorrhoid, when the external hemorrhoid is well defined, yes, we can do. Persistent second degree hemorrhoid, no need of hemorrhoidectomy. So let's see the explanation. Hemorrhoid can persist 10 days after sclerotherapy. The indication for hemorrhoidectomy includes third and fourth degree hemorrhoids, secondary hemorrhoid that have not been cured by non-operative treatment, fibrous hemorrhoid, and internal external hemorrhoid when the external hemorrhoid is well defined. So this is the question can be asked because it makes sense to ask this kind of questions, because hemorrhoids is one of the commonest clinical, because this makes sense, because this question makes sense because hemorrhoids is one of the commonest presentation find in Indian population, because we eat a lot of spices and even we eat a lot of fibers in our diet. Still this happening, reason is spicy food and oily food, so we have to avoid it. And let's see few differences between hemorrhoid and fistula. Fistula is a connection, so unusual tunnel that connects two sections of the body such as anus and skin and rectum and vagina. So symptom unpleasant smelling, discharge, and sometimes pain is a fistula. Causes traumatic events such as surgery, sometimes childbirth, infection, or having an inflammatory condition such as Crohn's disease can cause fistula. Risk factor for fistula is Crohn's disease again and difficult childbirth. Surgery is fistulectomy. Fistulectomy question can be asked here. The name of surgery can be asked. Fistulectomy. Treating inflammatory bowel problem can be prevented. And hemorrhoid, taking stool softeners can prevent hemorrhoids. But in hemorrhoid we know there is swollen veins that occur in outside of the anal canal. Pain, sometimes bleed with bowel movement. There's like this. Chronic constipation and childbirth can cause hemorrhoids. Then risk factors, we know this, having serious constipation and causing strain during defecation is one of the complications. Now Park's classification of fistulas, this can be asked. So type 1 is the intersphincteric type 1, type 2 is a transsphincteric is a type 2, type 3 suprasphincteric is a type 3, and type 4 is extrasphincteric. So you should know this classification also. Fissure, fistula, these are the differences. By image only you can know the differences. Now next, hemorrhoid versus anal fissure. Anal fissures, these are cuts or tear around the anus like this, and this is the anal fissure acute one, and this is the healed one. So causes of anal fissure is chronic diarrhea and sexual intercourse through anus. Then prevention, avoid spicy edible items and prevent and control constipation and diarrhea. Drink water regularly, regular physical workout, walk, and dietary fiber. So you can see it's just one step. If we take toward not eating spices, we can the Indian population will be spared from these diseases. So let's hemorrhoidectomy is there, and here is lateral internal sphincterectomy. So you should know this. Sometimes image can be given and they will be asking what's this. So sometimes anal fissure. So next question is question number 36. Question number 36. So this is what given. So patient presented with an opening at lowermost part of the back. It discharges pus. Since pus will be always having a sinus. So on examination it looks like the image given. So it's like sinus, pilonidal sinus. What can be the most possible diagnosis? I will go with the pilonidal sinus, but you should know few more things about pilonidal sinus. It's given in this: how it is acquired disease, how it forms, that too much hairy region, it may cause their like furuncle like thing or hair follicle grows within the sweat gland, and that can cause pilonidal sinus. So next we have, next question is related to 37 number question. According to NIHA's classification, categorize hernia defect by localization, size and type 3C. Before solving this kind of question, because this is asked every year, year after year, I will say, NIHA's classification, we have type 1, type 2, type 1, type 2, type 3 and type 4. Before knowing this, you should know what kind of hernias we have. We have two type of hernia, indirect and direct. Indirect hernia is congenital, most protrude through inguinal ring, directly protrude through inguinal ring. Then direct hernia protrude through back of the wall of inguinal ring due to heavy lifting and straining. This is direct hernia. Then coming to the stable, type 1 includes type 1 and type 2 NIHA's classification includes indirect hernia. That is, type 1 will be normal sized deep ring, in type 2 dilated deep ring, intact posterior wall. Type 3 and type 4 we have A, B and C. So A, that is direct inguinal hernia, B is indirect, and C is femoral. Same with type 4, direct, indirect and femoral, but the D is combined stuff that is being added here. So our MCQ will be solved on this basis. So what they are asking is nice the 3C, A direct, B indirect, C femoral. So C femoral hernia. This is the answer. So one more thing, that based on presentation we have protrusion through the abdominal wall, external hernia, internal hernia within the peritoneal cavity, and then based on the origin we have congenital protrusion through the preformed defect, acquired protrusion due to increased abdominal pressure and weak abdominal wall. Then we have according to the site, inguinal, femoral, apparatus, sciatic and umbilical epigastric incision and spiglian. These are names, but this stuff is very important because MCQs are asked on this basis. Then this is one more classification, EHS classification, midline and lateral. So according to the skeletal anatomy we have this, that is subxiphoid M1, epigastric M2, umbilical M3, infraumbilical M4, suprapubic M5 and lateral as it is L1, L2, L3. This time L2 was asked, I guess flank related some stuff was there, and EHS classification or something was asked. So now moving on to the next question. This is the question number 38. What is the name of this triangle? So before knowing this triangle, you should know both of the stuff. There's triangle of doom and triangle of pain. Triangle of doom, boundaries of triangle of doom, medially we have vas deferens, this. Then laterally we have gonadal vessels. Laterally we have gonadal vessels. Base, laterally we have gonadal vessels. Base is the peritoneal edge. Then apex we have deep ring or internal ring. Contents are iliac vessels and iliac artery, iliac vein. Sharp dissection should not be performed in this triangle as it may lead to damage of vessels, and damage of vessels means loss of blood. Loss of blood means dizziness, and dizziness is nothing but doom. So triangle of doom. So let's come to this question. Deep ring, medial border, ductus deferens, lateral border, gonadal vessels, posterior border, peritoneal edge. So it is triangle of doom. Now coming to the triangle of pain, medially lateral border of the doom becomes the medial of this triangle of pain, that is gonadal vessel. Superiorly we have iliopubic tract, lateral we have peritoneum. Content are 4 nerves. This can be the question. So 4 nerves: femoral branch of the genitofemoral, anterior cutaneous nerve of thigh, and lateral cutaneous nerve of thigh. So lateral cutaneous nerve of thigh. So this can be the question. So 2 questions, 2 MCQs. So next, moving on to this diagram, triangle of pain and triangle doom. Fixation should not be done in this area, that may lead to pain or dizziness, that is doom. So now coming to the 2 more condition I want to discuss, that is gastroschisis. And so two more condition I want to discuss is gastroschisis and omphalocele. So thing is here, so two differentiated things we can have: prematurity, gestational age, gastroschisis, and omphalocele at term. Defect size can be different. Omphalocele is a little bit big, and gastroschisis is 2 to 3 centimeters. Then malrotation in both possible: bowel character, inflammatory and edematous. Here, and both are normal, that is internal nutrition as well as bowel character normal in omphalocele. Commonest type is this. Omphalocele looks like this. Now, this is omphalocele. This is gastroschisis. Bladder extrophy. One more, sometimes we get confused with this: extrophy, bladder, or ectopia vesicae. So this looks like this. So questions can be given directly, image-based question. This Jan FMGE had question related omphalocele, so you can diagnose it very well. Now the question number 39. We are just 10 questions away. 15 questions. Which of the following is accurate about workup of patients related to varicocele? So varicocele, they are just asking investigation of choice. Varicocele means fluid means ultrasound. So in this case, high resolution ultrasound, color Doppler ultrasonography should be done, diagnosing suspected varicocele. So let's see the explanation. This will look like this: varicocele. Of course, this is easy, you can go with it. And the varicocele, what is varicocele? It's a benign condition, rarely associated with a renal tumor. Bag of worm appearance will be there. Infertility can occur because that varicocele will put pressure on testis, and that pressure will lead to temperature increase in testis, and that will lead to infertility. So temperature increases and varicocele, that will lead to infertility. Orchitis, that is infection or inflammation. Then hydrocele, that is avocado shaped swelling of hemi-scrotum testicle, may be impalpable, illuminates under light, generally painless. You can get above it, and ultrasound to confirm the normal testis. Hydrocele, we do Lot's plication. We know this, that is, we cut the seal and we suck out the fluid inside, and then we use catgut to suture it, and then over the period it heals and it won't secrete, that the secretions won't come later. Testicular torsion, in this case we should not procrastinate. If suspected, we have to do this surgery as early as possible. So hydrocele, clinical features, diagnosis and investigation is this. You should learn this. I will share the PDF, you can learn this. Next, number 40, question number 40. This is the most commonly asked question. Fourniers gangrene, and last time in Jan 2024 there was an image of Fourniers gangrene that was confused with septal hematoma. So that's why I have put this in the question list. This is Fourniers gangrene. So features of Fournier gangrene: except necrotizing fasciitis of male genitalia and perineum. Yes, it is true. Diabetes is a risk, possibly. Urgent wide surgical excision of the dead and infected tissue is essential. Testes need to be removed in all cases. So except, so I think the answer should be D. So testes need to be removed in all cases. No, this is wrong. So I think answer is D. Urgent wide surgical of dead, and it's not necessary. So these are true. This is false. So let's come to this is same. Fournier's gangrene is a necrotizing fasciitis of the male genitalia and perineum that can be rapidly progressing and fatal if not treated. Risk factors: urethral strictures, perirectal abscesses, poor perineal hygiene, diabetes, cancer, human immunodeficiency virus. So these all are Fournier gangrenes, necrotizing fasciitis. These all look same. So this looks same, but image can be like this. septal hematoma will be there, and there will be Foley's catheter inside, and this will be septal hematoma, and we will be confusing with it. So you should not confuse, because in this also Foley's catheter, but you have to see the openness and necrotizing facilities, but sometimes it can be shown like this also, so you should not get confused. So this is the flashcard about it. Signs and symptoms: severe pain, erythema, swelling, overlying skin tense, indurated, possible red-violet patches, male at birth, scrotum and penis, labia if female, gangrene can be there, dry textured skin with clear demarcation between necrotizing and viable tissue, signs of systemic toxicity. So severe pain, erythema. This is the necrotizing facet affecting genital area, perineum, consider surgical emergency, flesh-eating disease, life-threatening bacterial infection of soft tissue beneath the skin. We need to treat it as early as possible. Treatment, again, surgical treatment, surgical debridement of necrotic tissue, broad spectrum IV antibiotics, hyperbaric oxygen, reconstructive surgery if untreated, high mortality rate. Diagnosis is like this: blood culture we have to send, skin swabs, imagery, exploratory surgery can be done. So next question is 41 number question. What is the reliable non-invasive test for diagnosing venous insufficiency? So again, same question is repeated, but the asking pattern is different. Non-invasive diagnosing venous insufficiency. So this is again venous insufficiency, duplex ultrasound. Ultrasound is a friend of fluid, or fluid is a friend of ultrasound. So this we like this. Then we have this few slides I want to share. Thrombophlebitis. So thrombophlebitis, then DVT, then varicose, and why I wanna share at once, because thrombophlebitis eventually will lead to DVT, and eventually will lead to DVT. So thrombophlebitis means increased coagulability. Virtuous triad will be seen here also. Virtuous triad question will be asked. So what is virtuous triad? You have to see hypercoagulability, blood stasis, and vessel injury. So this one question. Now thrombophlebitis types: migratory thrombophlebitis is the significant superficial thrombophlebitis. Causes can be most commonly needle catheter, then pregnancy, estrogen related diseases. Then we have DVT complication. Thrombophlebitis will turn into DVT in future. Then venous duplex ultrasound, we have discussed this. Imaging studies, lab results, elevated D dimers can be done. Venography can be done, ultrasound. And long-term treatment is prevention, that is anticoagulant medication, that is warfarin and heparin. Filters in the inferior vena cava to prevent pulmonary embolism. This can be done. This can be the question. Next, DVT is a deep clot will be there in the deep veins, so can lead to pulmonary embolism. So it is one of the most important to diagnose as early as possible. Virtuous triad should be confirmed every time. Diagnosis, medical history, and physical exam. Well score can be used here. High probability ultrasound, low probability D dimer blood test should be done. Pain, that is symptoms: thrombing or cramping pain, redness, swelling, edema will be there, hard and sore veins, large calf diameter will be there. So this is this. And last, varicose vein, again diagnostic Doppler, same similarities, that's why we have to discuss these cases together. Varicose, as I have told earlier, this vessel Pampiniform plexus around testis will increase the testicular temperature, that will lead to testicular atrophy, and that will lead to infertility. So this is one more question added. Embolization or surgery can be done here. And most common on the left side, looks like a bag of worm, a large standing vein, smaller vein, injury flat. Treatment: radiofrequency or laser ablation, stereotherapy, and others like this. So now we are done with most of the stuff. So let's move on to the 42 number question. A 40-year-old woman is admitted to the burn unit after an industrial fire at a plastic manufacturing plant with burns to face and arms. ECG has been done, ST elevation, and initial chemistry panel. Arterial blood gases reveals an anion gap metabolic acidosis with normal arterial carboxy hemoglobin. What is the most appropriate next step? So let's see burns first, how burns are there. So from this table, at least 7 to 8 questions can be made. So you should by heart this table and this table was with me every time. Like before exam, I was revising it every time. So because it's very difficult to learn stuff for me. So superficial burn, there are 1, 2, 3, 4, 5 type of burns. We have superficial, that is first degree, superficial partial thickness second degree, deep partial thickness, full thickness third degree, and full thickness fourth degree. So you have to see the commonness, that is scald will be seen in second degree and third degree burn. This scald thing, short flash, and depending on you have to segregate it. Epidermis only, then first degree, epidermis, papillary and epidermis and papillary dermis, skin appendages, epidermis, and this you have to learn it. And then healing time you have to see 3 to 6 days, superficial first degree, 7 to 20 days, superficial partial thickness second degree, more than 21 days, second degree again deep partial, and never heal, this is third degree, and never again, this is that. So again, on the basis of treatment you can segregate them. So see, surgeries will be required in case of 4th degree burn, surgical intervention, functional impairment, deep partial thickness burn plus surgical excision. Grafting can be done in 3rd degree also. Cleaning and topical agent will be in the 2nd degree, and grafting earlier as function, grafting can be done. Complications, and you have to learn this table. I won't be discussing it in much detail because it will utilize a lot of time. You should learn this table. I will be sharing the PDF. So these are the pictures. Most important: present capillary field time, present in epidermal and superficial dermal. You have to do this. Sluggish, there is mid dermal, absent in deep and full thickness burns. So you have to learn this blisters and how it appears. Sensation is there or not there. You have to blanching, non-blanching. You have to learn these tables. So about this question, so there was a fire. So carboxyhemoglobin, so carbon monoxide mixed with the blood, and it will form compound. So what happens here? So what we have to do? So administration of 100% of oxygen and hydroxycobalamin. So why? This is the reason. So what happens? Cyanide inhibits cytochrome oxidase, which is required for oxidative phosphorylation. Treatment consists of sodium thiosulfate, hydroxycobalamin, and 100% oxygen. Sodium thiosulfate works by transforming cyanide into the non-toxic thiocyanate derivative, but it works slowly and is non-effective for acute therapy. Hydroxycobalamin quickly complexes with cyanide and is excreted by kidney. Is recommended for immediate therapy. In majority of patients, lactic acidosis will resolve by ventilation and sodium thiosulfate treatment become unnecessary. So basic physiology question is this. So but it can be asked in this way also. So you have to learn this anyway. So just I have given this question to make you a little bit smart. So I guess it will work. So let's come to the question number 43. So slow growing tumor but have propensity for distal metastasis. Scar tissue is devoid of lymphatics, so no lymphatic spread. Lymphatic spread can still occur when it invades normal tissue. Also nerve ending are not scar tissue. So pain is a late feature. True about this condition. So what is this condition? First we have to find out. So this is probably a cancer related to skin. But which type of? So before this we have 2 type of cancer, that is basal cell carcinoma and squamous cell carcinoma. Basal cell carcinoma, most common type of skin cancer. Shiny pearly papule or nodule is the umbilicated center, and telangiectasia is the. In case of squamous, more common in immunosuppressed or transplantation. Hyperkeratotic lesion with crusting and ulceration can be more aggressive than basal cell carcinoma. Both usually occurs on sun exposed area, but basal cell carcinoma grows slowly, and in this case basal cell carcinoma will look like this. Umbilicated lesions will be there. Basal cell carcinoma or rodent ulcer. Then squamous cell carcinoma look like this, and these are the few presentation of basal cell carcinoma. So let's discuss this question. So what is this? So lymphatic spread can still occur when it invades normal tissue. Also nerve endings are not in scar tissue. Pain is a late feature. True about this condition. Late feature means probably a slow growing tumor. Distal metastasis is there. Scar tissue is devoid of lymphatic. So slow growing tumor, a directly basal cell carcinoma. Aggressive and fast growing tumor, they are painful. Lymphatic spread is common, is most common type. So true about this condition is lymphatic spread is common, is not possible. Aggressive and fast growing squamous cell carcinoma. Squamous cell carcinoma is the most common type. So true about this condition. So I don't know how they frame this question, but squamous cell carcinoma is most common type. This must be answered. So it was a true or false question. So this is a true statement. This is a false statement related to BBC. False statement. False statement. So they framed it like that. So the Bailey related topic was the in Bailey it has given. So this was true or false question. So this kind of confusing stuff can be asked. So now I have got fatigued. Now let's come to the last few questions. So melanoma, you should know what is this. Melanoma is a melanin secreting tumor. So skin cancer, again you should learn this and you should know the stages. It will be covered in derma again, so you should know this table. That's why I have given this to differentiate. Then we have 44th number question. This is the case of a 24-year-old male truck driver comes to the routine examination in order to renew his commercial driving license. The patient is asymptomatic, medical history is unremarkable, he does not engage in risky sexual behavior or take any medication, HIV test was negative, smoke less tobacco for 14 years, physical vitals are normal, dentition is poor and oral mucosal is seen, the oral mass is also no cervical injury, the remainder of the examination is normal. So what is this? Does it look like candidiasis? No, since there is no oral thrush. Leukoplakia, maybe lichen planus? No, for sure. Oral hairy leukoplakia? No. There is no hairiness, so it's leukoplakia. So one more differential it is we can differentiate it with is erythroplakia. So background painless slow growing lesion on mucous. So background of erythroplakia is painless slow growing lesion on mucosal membrane or oral cavity, potential precancerous condition, bleeds easily and scarred, causes heavy smoking, chewing tobacco, excessive alcohol use, poor oral health, long-term trauma to oral cavity, advanced age and HPV infection. Diagnosis, medical history exam and exfoliative cytology, fluorescence staining and colored in blue. So this you should know, that is erythroplakia looks like, and this is leukoplakia. So this was a question. Then we have last question of the day. So 30-year-old man had a pleuromorphic adenoma removed from his left parotid gland. His post-operative course was uncomplicated. 2 months later, he noted that his left cheek became wet while he wet. 2 months later, he noted that his left cheek became wet while he was eating. Believing that the saliva was being discharged from the parotidectomy scar, he went to the emergency department and an examination revealed that the wound has healed well. There were no sign of fistula. As soon as the patient ate a lemon wedge, his left auricle and parotid region become flushed and sweaty. What is the diagnosis? So to diagnosis like this, it's easy since it's related to parotid left side. Only one side is involved. Post-operative course was uncomplicated. Cheek became wet while he was eating. Excessive sweating. Fistula, no signs. So it's a Frey syndrome. But if they add image like this, then it's a short Frey syndrome. So what's the Frey syndrome? Frey syndrome, fact, it is a neurological disorder resulting from damage to near parotid gland and from damage to facial nerve, often from surgery. Symptoms: redness, erythema, sweating, cutaneous Auriculotemporal nerve, usually in response to gustatory stimuli. Question number 2. Pain in the same area, often burning nature, gustatory neuralgia pain. Question number 3. Causes: it is generally due to side effect of surgery or near parotid gland, or maybe injury to the auriculotemporal nerve which passes through the parotid gland. Question number 4. Then diagnosis can be done by doctors based symptoms. Management: there is no effective treatment, but various options are available. Injection of botulinum toxin A. 5. Question number 5. Surgical transection of misdirected nerve fibers, only temporal treatment. So 6. And application of ointment can be done, but it's not useful. Complication: face syndrome causes hyperhidrosis, that is excessive sweating, excessive perspiration from the skin. Features include sweating, skin maceration, and fishing. So here I end the session T and D. I would have added more questions, but why I didn't add, because I know you guys are well prepared for the exam and you don't need much knowledge now, like much facts or much things. Just I have done this session to show that how questions can be framed, how easy can be the exam, or how difficult can be, or how weak questions can come. So that's why all type of questions were there. So still I want to add a topic to revise in the last minute, that is today you should do ATLS protocol, GCS code, triage, blunt trauma abdomen, most common organ injured in the cases, suture color grade, Foley's color grade, SIDS, MODS, sepsis, shock, gangrene. These are basics, because this thing you will be experiencing in casualty department when you will be working. Now I am working in casualty and I know how important is to learn this, and during my preparation I was also very weak in this topic, but these are most important topic, because you can save the patient's life by just knowing these steps. So this is most important, and I haven't added it because I just don't want to make this video too long and too boring, because I got bored after making this video now. So this is important stuff, and I have given the important topics you can revise. Those I haven't covered in this video, you can go through the list and revise from your last minute. From this video, most of the stuffs are covered. At the end of this video, I just wanna say is this, that is, I did my best in FMG and cracked it in first attempt, even after doing every chores of life, from part-time work till enjoying my life as a traveler, and of course studied 6 hours on average daily. I was also feeling nervous, anxious, and whatnot. Don't look up to negatives, but find possibilities always. So consistency is the key. If I can, then of course you can, you will, and you must do it. To all the FMGs and their families, because we always go through a lot of problems, and life is much more difficult for us always. But still, I don't want to victimize FMGs, but be smart and be yourself always. You will have great life ahead. So that's it.